Mr. Henderson. How are you today?
Good.
Good. My name's Cassandra. I hear you're here for a work physical?
That's right.
Okay. Do you have any medical conditions that you'd like to talk about today?
Nope.
Okay. Do you have a past history of anything? Diabetes, high blood pressure, anything like that?
Nope.
Okay. Do you have a family history of any of those kind of problems?
I don't.
Okay. Have you had any recent surgeries or hospitalizations?
Nope.
Okay. Do you take any medications every day at home?
I don't.
Are you allergic to anything?
Nope.
Okay. Do you use drugs, alcohol, or tobacco?
Mm-mm.
Okay. So for this assessment today, we're just going to inspect the abdomen. We're going to begin by looking at the skin. We're going to inspect it for any kind of striations, any scars, any dilated vessels, any rashes, or any lesions. Next, we're going to look at the umbilicus. We're going to note any kind of bulges indicating a possible hernia. We're going to look at the contour or the shape of the abdomen. Is it flat? Is it distended? Is it symmetrical? We're also going to look at all the rest of the areas of the abdomen for any kind of bulges, possibly on the flanks indicating ascites, or over the suprapubic area indicating a distended bladder. We're also going to inspect the inguinal and the femoral areas. If we suspect an intestinal obstruction, we can monitor for peristalsis of the abdomen. We can also look for the aortic pulsation. An increase in the pulsation indicates a possible AAA or increased pulse pressure. After the inspection, we're going to auscultate. A skilled practitioner can use auscultation to detect changes in bowel sounds indicating possible inflammation or obstruction. With our stethoscope, we're going to listen with the diaphragm. We're going to listen over the epigastric area, as well as all four of the abdominal quadrants. We want to listen for normal bowel sounds. Normal bowel sounds sounds like clicks or gurgles. There's usually 5 to 34 per minute. If the patient has high blood pressure, we can also listen for bruits. Bruits are best heard with the bell of the stethoscope. We want to listen over the epigastric area, as well as the aorta, the iliac arteries, and the femoral arteries. Bruits are an unusual sound that the blood makes as it rushes past an obstruction. We also want to listen over the liver and the spleen for any kind of friction rubs. A friction rub over the liver can indicate a tumor or inflammation around the liver. Any kind of friction rub over the spleen can indicate a splenic infarct. After we've auscultated the abdomen, we want to lightly palpate. We want to make sure and auscultate first before palpation, because palpating the abdomen can change the bowel sounds. So for light palpation, we want to keep the hand and the wrist horizontal. Just want to lightly press the quadrants of the abdomen, as well as the epigastric area. We want to assess for tenderness, muscular resistance, and possibly even superficial organs and masses. So if we feel any kind of muscular resistance, we want to try to assess if it's voluntary or involuntary. To do that, we can have the patient relax. We can have them open mouth breathe with their jaw open. Also on expiration, the abdominal muscles kind of naturally relax, which makes it a little bit easier to tell if the resistance is voluntary or involuntary. After light palpation, we want to deeply palpate. You can either do it with one hand or with two hands. Deep palpation can help us assess for any kind of masses in the abdomen. We can also assess for rebound tenderness with deep palpation. To do that, you want to press firmly with your fingers, and then you want to withdraw quickly. If the patient feels more pain on withdrawal, it's a positive sign for rebound tenderness, which can indicate peritoneal inflammation. After we're done with the deep palpation, we want to assess the liver. The liver can be a little bit difficult to assess because of the rib cage. To assess the liver, we want to start out with percussion. We want to go to the mid-clavicular line below the umbilicus to an area of tympany, and we want to begin by percussing. We're going to continue to move upward until we reach an area of dullness. But then we also want to start from the top and go down at the mid-clavicular line and over the ribs. We want to percuss, again, in an area of tympany until we reach an area of dullness. You can measure the area of dullness. An enlarged area of dullness can be indicative of an enlarged liver. After we percuss the liver, then we want to palpate the liver. Okay, so to palpate the liver, we're going to slide our hand underneath the 11th and 12th rib. We're going to put our other hand just right of the rectus abdominal muscle, below the area of dullness. We're going to have the patient take a deep breath. We're going to attempt to palpate the border of the liver. On inspiration, the liver is generally palpable about 3 centimeters below the right costal margin. In some patients, you won't be able to feel the liver. Firmness or hardness may indicate an abnormality with the liver. As you're palpating, if you feel an oval mass below the edge of the liver, it can be an obstructed or distended gallbladder. Also, with an obese patient, the hooking technique can be helpful to assess the liver. You want to place both hands just below the area of dullness. Have the patient take a deep breath, and you want to press in and up. So after our liver assessment, we're going to assess the spleen. When the spleen enlarges, it stretches anterior, downward, and medially, and often causes an area of dullness in an area that's normally all tympanic. So we want to begin by percussing. We're going to go to the left lower anterior chest wall, and we're going to move laterally. We begin by percussing. You want to note the extent of tympany. If tympany is prominent, then splenomegaly is not likely. Let's see. So to check the splenic percussion sign, you want to percuss the lowest interspace in the left anterior axillary line. Right there. The area should be tympany at rest, as well as when the patient inhales. So have the patient inhale. Any change in the tympany can indicate splenomegaly. So to palpate the spleen, we're going to reach across the patient and press forward on the lower rib cage and the soft tissue. We're going to take our other hand and put it just below the left costal margin and press toward the spleen. Again, you're going to ask the patient to take a deep breath. You're going to try to palpate the spleen. You want to note any tenderness, the splenic contour. You also want to measure the distance between the tip of the spleen and the left costal margin. You can also repeat that same thing with the patient lying on their right side. So again, we're going to put our hand back behind the ribs and the soft tissue, go right below the costal margin, and we're going to press in and try to feel the tip of the spleen. So next we're going to assess the aortic pulse. It can be felt by pressing deeply on the upper abdomen, just left of the midline. Pain on palpation may indicate an impending rupture of a AAA. And lastly, we want to assess costovertebral angle tenderness. Have the patient sit up. You want to place the ball of one hand at the costovertebral angle and strike it with the ulnar surface of the other hand. Do it on both sides. Any tenderness indicates pyelonephritis. So that concludes the abdominal assessment. Any questions?
Yes, I have 5 questions.
You're going to cut that out now.